confines of their residence, in order that they may maximize their contributions and fulfill their goals as a family member and members of the society with a minimum of conflicts. In accomplishing this end, it is felt that the self-respect of the individual can and will be enhanced. The agency is also a vital member of its community. As an employer, the agency practices non-discriminative and strives to provide opportunities for personnel's and professional growth. As an integral part of the business community, the agency makes every effort to serve the people with attention to current areas, practices, and specific needs. It is required that every employee complete a company orientation. Each employee will have an orientation checklist completed and placed in their personnel file. The following are items that are included on the orientation checklist: agency mission, vision, and plan, which we've already read; types of care provided by the agency policies and procedure; personnel policies and job descriptions; clients' rights and grievance policy; confidentiality of patients' information, which is the HIPAA; ethics; supervision and evaluation; home safety, which includes bathroom, electrical, environmental, fire hazards, safety issues in the home; infection control; patient care responsibilities; mandatory in-service, which includes HIPAA and infection control for all services, with additional mandatory in-service of blood-borne pathogen, medical device reporting, and respiratory disorders, tuberculosis for employees with direct care contacts; understanding and coping with Alzheimer's disease and dementia; community resources; cultural diversity; identifying and reporting abuse, neglect, and exploitation; fraud, abuse, and whistleblowing; quality assurance; documentation; incident and occurrence reporting; advanced directives; and final topic, received photo ID badge. These are all the topics covered on the employee orientation book. The agency is dedicated to providing the most quality personnel to the patients in his or her own home in order to maximize and fulfill his or her goals as a member of the community. Services are available 24 hours a day, 7 days a week, using an answering service and on-call procedures after normal working hours, weekends, and holidays. As needed, staff may be assigned to make patient visits after normal hours. We offer skilled nursing services to the extent that is appropriate for professional staff, and either hired or contracted for additional services listed below will also be available. The services we provide include skilled nursing services, which include the registered nurse and the licensed professional nurse. We also provide physical therapy, occupational therapy, and we have the PTA and the CODA to assist these disciplines. So let's go right into the nursing orientation portion. And this can cut across to physical therapy as well. In this section, we're going to take the time to get you signed up into our system that we normally use, which is called Access. So we're going to give you access into Access. So the next step is to take the time to download the Signal app. This is the app that we use to communicate amongst ourselves, whether it's from the office, whether communicating with a physical therapist, a nurse, myself, Victoria Adelaide Martin, whoever you need to reach, we're all on that Signal app. So let's just take the time to download that app on your phone. And once you have done that, send me a text message so that I know that you're on there, so that I can put you on the groups that are in that app. The next thing is to download the Access app on your phone. We definitely do use the Access app on our phone while we're on the field to do the most documentation that we're able to do while we are in the field. The next thing is to educate you on what the Access Planner is. The Access Planner can only be found on the website and not in the app. As we go on, you will realize that there are certain things that can be found on the website Access and not in the app Access, because not every information is on the app. .com, you will click Login, and it will bring you to the login page. You will put your email address, click Next, put in your password, click Secure Login, login successful, click OK, and it brings you to the first main page. Over here is where you have your Access Planner, and this is how you're able to map out your visits for the day. For instance, I can change my zip code to where I normally start from. I submit it, and then I will click the minus button till all my patients come in. And for today's assignment, this is my location. I can decide to start right from here, go here, and then come right down here and finish up here. Or I can decide to do 1, 2, 3, finish up closer to home, and then go home. So depending on what route you want to go with, based on what time the patient is available, based on patient's preference, that is where you will go. Okay? So once you have mapped out your visits, you can go ahead and call your patients to see them. So to go into the Access system or the dashboard, you will click Comfort Plus, and it will bring you to the dashboard where we have reviewed already. There are 2 insurances that we take at Comfort Plus Caregivers. These insurances include Commonwealth Care Alliance and Medicare. So for Comfort Plus, to be able to have a patient join our agency or be admitted into our agency, we get referrals from the hospitals, Bay State Mercy, Holyoke, nursing homes, doctor's offices, and many different routes. And once this patient's referral comes to us, the referral is reviewed, and then it's given to the director of nursing, who also reviews it. And once the patient is deemed appropriate for home care, the patient will then be admitted into the agency. For a patient to qualify for home care services, like I said, the patient has to be homebound. And to determine that a patient is homebound, the doctor has to have a face-to-face meeting or face-to-face appointment with a patient. When we receive our referral, we require 2 documents from our referring source. And these 2 documents include a DC summary and a face-to-face, or a last hospital visit note and a face-to-face, or a wound care order and a face-to-face, depending on where the referral is coming from. So once we have these 2 documents from the referring source, for example, if a patient is coming from the hospital, we need a discharge summary and a face-to-face. And the face-to-face is what determines if the patient is homebound and what services they need for home care. The face-to-face has to say what services the patient needs, when the face-to-face occurred, which doctor completed it, and when they completed it. For the policy, we have to see this patient within 24 to 48 hours, but Comfort Plus always pushes for 24 hours. So within 24 hours of receiving the referral, the patient is seen. Sometimes we are able to see the patient on the same day depending on their needs. If the patient, for example, needs an IV medication administered that same day, the patient will be seen. So once the patient is deemed appropriate for home care and the patient is seen within the 24 to 48 hours and admitted, the nurse goes in to do a start of care, which is also called an admission. And for the most part, it's also called an OASIS. So it's called an OASIS D1 start of care. An OASIS D1 start of care is the first visit that will happen in the patient's home. On rare occasions, patients come to us with just a need for PT, which is physical therapy. And in that instance, the patient will have an OASIS D1 start of care PT. So that means that patient is a PT only case. But if it's nursing and physical therapy, the nurse will start the case. And for that, like I said, we will do an OASIS D1 start of care. So once the OASIS D1 start of care is completed and other visits are scheduled, we have the RN or the LPN going to do visits. Bear in mind that the OASIS D1 start of care can be completed only by the RN. So after it's done, the LPN or even the RN will complete skilled nursing visits based on the frequency from the start of care. So at 30 days, our LPN has to be supervised. So the LPN is supervised at 30 days. There are 5 OASISes that you should know about. If you should ask, what is an OASIS? An OASIS is basically a collection of information, and it's just a bunch of questions that you ask the patient when you assess them in order to get the most up-to-date information on the patient's health. So there are 5 OASISes that you should know about. The first one, which we already talked about, the OASIS D1 start of care, which is also called an admission, and which is also the initial visit when we're going to assess the patient. The other OASIS that I would like us to talk about is the OASIS D1 transfer. OASIS D1 transfer is when the patient goes to the hospital within their episode of care. The patient is transferred to the hospital. The next OASIS that we'll talk about is the OASIS D1 resumption of care. So when the patient goes to the hospital and returns to the agency completes a resumption of care, which also means resuming the patient's services. Another thing is OASIS D1 recertification. So at the end of the patient's episode, at the end of the patient's 9-week episode, at the end of the patient's 230-day episode, we complete the OASIS D1 recertification. Either we do the OASIS D1 recertification, that means we are recertifying the patient into a new episode, or we complete an OASIS D1 discharge, discharging the patient to end the services. So we've talked about, I believe, 4 OASISes, which is the OASIS D1 start of care, OASIS D1 transfer, OASIS D1 recertification, OASIS D1 resumption, and then OASIS D1 discharge. We've talked about 5 OASIS D1. Please make sure you remember these because you'll be quizzed on those. All right, let's go over reviewing a patient's chart. So we're gonna go over 2 examples, or maybe more, who knows. So let's view one for this patient. So for this patient, for example, we started the patient's service all the way in (2020). So on 12/1/2020, we started the service, which is the Oasis D1 start of care. We went right into the skilled nursing visits, communications, physician orders, more communications, more physician orders, right through more physician orders, communications, skilled nursing visits, and then we recertified at the end of the episode. And then we go more into seeing the patient, skilled nursing visits, physician orders, communications, all the way to recertifying the patients again. We repeated the same thing and recertified right here, okay? And then we go through again for another 9 weeks, 30 days, 30 days. We redo it again. We go through for another 9 weeks, 30 days, 60 days, and recertify. We do the same thing again, recertify. We keep going and going and going. This patient has never been discharged, okay? On the other hand, we have another patient that we'll go over. For this patient, she's been with us for a long time as well. We did the start of care 7/30/2021. It's been almost a year. And then we discharged at the end of the episode. She came back on 10/14. She was discharged 9/24, came back 10/14 for start of care. We continued to see this patient, and then we discharged again on 12/10/2021. The patient came right back on 12/27/2021. We continued to see this patient. We went all the way through some nursing visits, communications, physician orders. We recertified on 2/23/2021. We continued to go. We transferred the patient on 4/9/2021, and then we resumed on 4/21/2021, and then continued throughout the episode. We recertified on 6/24/2021, and till date, we're still seeing the patient. Let's do one last example. The next example will be Elba, and this patient service was started on 3/23/2022. We see the patient, skilled nursing visits, physician orders. We recertified on 5/20. We continue to see the patient as it is till current. For this patient, okay, for this patient, it's a little complicated, but we'll go over it. So this patient was started on 12/27/2021. Then, even before we were able to see the patient was transferred on 12/29 to the hospital. PT went into eval right after the, was gonna go eval, but it didn't happen because the patient was in the hospital on that same day. So PT missed the visit. Then the patient came back on 1/3/2021. We resumed. We continued to see the patient. PT saw the patient and discharged on 1/28. We transferred the patient again on 2/7/2022. Resumed on 2/12. And then continued to see the patient. We transferred the patient on 2/18/2022. Then the patient came back. We had to start the service because the episode was over. So let me take this time and go over something right here. So this is the same patient that we're reviewing, and I just want to look at it in the calendar form. Okay. Okay. So we started to see the patient here. The patient was transferred right here on the 29th. We continued to see this patient for transferred. We resumed on the 3rd. We continued to do our skilled nursing visits. Okay. More skilled nursing visits. And then the patient was transferred on the 7th. And then we resumed on the 12th. And then we continued to do more skilled nursing visits. And then the patient was transferred again and was transferred again right here. And then the episode ended. So when the transfer ended here, we had to do a new start of care, because when the patient came back, we could not resume because that episode was over. So this is the 9-week calendar I've been talking about. So let's count this. So right from here, 1, 2, 3, 4, 5, 6, 7, 8, 9. This is 9-week episode. 30-day calendar, 27th to 27th to 24th. So this is the first 30, about the first 30, and then the next 30. But this should be able to divide into exact 230 episodes. And if you should count the same numbers individually, 1, 2, 3, 4, 5, you should count 60 days. So if a patient should be transferred and returned in this same 60-day episode, then we can resume. But if it's outside of it, so the patient was transferred here, right? They didn't return until a new episode or until that old episode was over. So if they come after that old episode was over, we have to do a new start of care. So we do a new start of care because the episode was over, like I said. And then we continued to see this patient, continued with more skilled nursing visits, then more skilled nursing, more skilled nursing visit. So more skilled nursing visit, I'm just going over that. Over here, the patient was transferred again. So it was transferred on the 8th. It says it right down there, Oasis D1 transfer. And then she came back as a resumption of care on the 12th of April. We continued to see this patient, continued. Another transfer on the 19th. We resumed on the 22nd. We continued to see the patient. We went more, hold on, let me see. We saw more visits right here. We transferred the patient right here. More, we resumed the next day. While I say that, if a patient is transferred and comes back in less than 24 hours, we just continue our regular visits. But if they stay in the hospital for more than 24 hours, that is when we resume their services. So if we hear that the patient is in the hospital, we wait to see if it's gonna be more than 24 hours. If it's more than 24 hours, we will schedule the transfer. And then when they return, we resume. So we continue to see this patient. continued, and then we transferred here again, and then resumed. So this patient was sort of complicated because the patient kept going to the hospital and returning and coming back. So there were so many transfers or resumptions in the episode. But the reds in here are missed. The purples mean there are multiple things scheduled. The green is completed and the blues are scheduled. So that is it for reviewing the episodes and the charts and all of the good stuff. Okay? Thank you. So remember I told you that the LPN is supervised every 30 days, 30 days in the episode. I want to show you how the LPN supervisory visit looks like. So the LPN that we're supervising's name will come up here. We'll put it here. And the LPN does not have to be present for the supervision. So that goes right here. The date that we're supervising, and we go through these questions. Maintains an open communication, process with the patient, arrives for assigned visits as scheduled, follows the patient's plan of care for completion of tasks as assigned, demonstrate competency with agency task, inform supervisor of client's needs and changes in the patient's condition as required. 6, compliance with infection prevention and control policies and procedures, honors client's rights, changes made to client's plan of care, deficiency in nursing services identified with need for competency evaluation required. Is this patient requiring insulin? Is the patient receiving wound care services? And is the patient at higher risk for hospital readmission? So this is the questions that we go over for the LPN supervisory visits. Missed visits. So let's say, for instance, you go to see a patient and the patient is not home. You need to complete a missed visit. The missed visit is completed at the home, my schedule, my task, and right by the visit that you want to miss, you will click on the missed visit form that is on the side. So for example, let's miss a visit for one of my patients. So I'll go into Sherry Veloso. I will miss the SNDC summary. I will click Miss Visit Form. I will click Order Generated. I will say yes. Physician Notified. I will say yes. Reason. I will put what my reason is. And I will put my comments. SN went to patient's home as planned with no open to lock door. Okay. So let me fix things here. So once this is done, I will sign. Once I sign this, that is not the end of it. I will have to create an order for the missed visit because every missed visit needs an order. So you will click submit, but for this purpose, I will click close. So once you submit it, you will come into the patient's chart. So for whichever patient it was, we'll go into the patient's chart. Look for the patient, go to new order, and then right here, you will do missed visit. And do other. There's a template for missed visit if you want to use it. That's the wrong one. Right here. And then you would say miss visit on. So if it's today's date, you will put whatever date it was. And then whatever date it was. And then you would say that the PCP office was notified on the date and the reason. And then you can go ahead and write your reason in here that no open to lock door. And then you will sign. Click order read back and verify and sign. But remember, once you sign, these 3 dates, 1, 2, 3 have to match. You cannot miss the visit on the 6th and then sign it for a different day. And the dates that you're missing the visit is what's supposed to be here. So technically 1, 2, 3, and 4 dates have to match. Once you sign, you create your order. Do not save your order. Create the order. Okay? All right. So the next thing is to go over the skilled nursing visit, how to document a skilled nursing visit. So to document a skilled nursing visit, you will go into your home, My Schedule, My Task, and then click on the skilled nursing visit that you need to document on. So once you do that, it will bring you to this tab. Over here, you put your time in and time out. And this time in and time out should be anywhere from 15 to 30 minutes. Once that is done, you will put in your vitals right from your temperature, the route, respirations, O2, whether it's on oxygen or on room air, pulse, whether it was apical lying, apical sitting, and all of that. Whatever it was, you can put that. Your blood pressure, whether the patient was lying, sitting, or standing, you will put that. The patient's weight, if we're monitoring weights every visit. And if the patient has other additional measurements, such as the blood sugars, random blood sugar, abdominal girth, hemoglobin A1C when it was done, and all other measurements that's necessary for the patient's care. So we go right into here. So this is your head to toe assessment. So neurologically, is the patient alert and oriented ×3? Do they have any abnormal behaviors, such as are they agitated, anxious, abusive, combative, difficulty coping with altered health status, delusional, excessive, exhibits signs of depression, hallucination, impaired decision making? All of that, whatever applies to the patient, please select. Anything here that applies to the patient, some of them, if it has more information, when you click, it will take you right into it, and then you can click what is most appropriate. I recommend that when you are new to this documentation system, you should click into things so that you familiarize yourself with where to find things. Okay, for example, if they're hearing impaired, it takes you right into if they're deaf, if they are bilateral hearing impaired, left, right, all of that. If they have any tremors, where do they have the tremors? You can put it in bilateral lower arms, or bilateral lower extremities, or wherever they have the tremors, you can put that there. And then we go into respiratory. Whatever issues they have, do they have a cough? Is it productive? Is it non-productive? Are they using accessory muscles? Abnormal breath sounds? Whichever you think, are they on oxygen? Is it intermittent? Is it continuous? Are they tachyphenic? So whatever you think is the issue with the patient, you can put that. When you listen to the lungs, does it sound different? What did you hear? You can put that in. So you cannot leave any section empty. And for the most part, whatever is the primary reason why we're in the home, you will go into that system more and document in there to reflect how the patient presents. So under cardiac, was the patient activity intolerance? Did they have abnormal heart rhythms? Did they have an abnormal heart sound? Is it any of these? Did they have an abnormal lower extremity appearance? Whatever you thought it was. Were they fatigued? Were they osteopenia? Do they have osteopenia? Do they have hypertension, orthostatic hypertension? Last bowel movement, you need to find out at every visit and put the date that they had the last bowel movement. Did they have any constipation, diarrhea that you had to address? Are they bowel incontinent? Are they on laxatives? Are they abusing your laxatives? Do they have any pain? Do they have an ostomy? Are they nauseous? Rectal bleeding, tenderness, vomiting, whatever applies to your patient, you can put that in there. Genitourinary, do they have a bladder distension? Do they have abnormal control? That is, are they incontinent, functionally incontinent, stress, urge, retention, whichever you thought it was. Abnormal urine appearance, are they urinating at night? Do they have a weird discharge? Are they on dialysis? And if you put that they are on dialysis, is it hemodialysis, is it peritoneal dialysis? What dates are they doing it? Did you assess their access site? Did they have the thrill, the bruit? Did you have an issue with that? Musculoskeletal, are they a high risk for falls? Do they have a hip replacement or a knee replacement? Do they have any amputation? Limited range of motion, poor balance, muscle weakness, unsteady gait, whatever you thought it was for musculoskeletal. Integumentary, do they have a wound? Do you have to go into documenting for wound? You click on the wound manager and it will take you into another page to document on the patient's wound. And to document on the wound manager, it brings you in here, and then you just need to confirm and make sure this is the treatment that you provided. So for this patient, it's a wound vac. And then did you do measurements? Measurements are done every Friday. So if it was a Friday visit and you did measurements, you're gonna put it right in here. And you're gonna go into documenting for the tissue type, the surrounding wounds, the wound edges, whether there was drainage, odor, undermining, talloning, pain, wound type, infection, and all the good stuff. And then you will complete. Once you do that, did the patient have pain? If it was a yes, you go through the questioning. If it was a no, you would either say they never have a pain, or they have pain but it doesn't interfere, or they have daily but not continuously, less often than daily, whatever you thought it was. Endocrine, do they have anemia, anticoagulation used like a heparin or a Coumadin, whatever anticoagulation they're using? Do they have any cancer? What kind of cancer do they have? Do they have hypothyroidism or hyperthyroidism? Do they have diabetes? And then you can select who helps them perform their blood sugars. You will look through their glucometer and put in what their ranges are and what issues you found. Nutrition. Are they having difficulty chewing, dysphagia, ill-fitting dentures, which is a sign of weight loss, anorexia, fair appetite, poor hydration, sore throat, tubing or feeding present, and what kind of tubing are they using, and what feeding do they have, if they're on TPNs or lipids, if they have any weight loss or weight gain. And then labs, was there labs, any form of labs during the visit? Infection control, universal precaution for every patient. If you had to dispose of sharps, if there's a new infection suspected, and if there's any new infection suspected or if the patient has started on any antibiotics, you have to add an infection log. And when you click that, it's very self-explanatory. So we'll go right into homebound status. Is the patient ambulatory? Do they ambulate with a device? Are they bedfast or chairfast? Do they use an assistive device? And the homebound narrative is auto-generated from the plan of care. But if there's nothing here, you can write in why you think the patient is homebound. Maybe they're homebound because they can leave home unassisted, or they need an assisted device, or they have to always leave home with someone, whatever reason. But for the most part, there should be something in this box already. Plan of care profile. Always you have to review or revise the plan of care with either the patient or someone in the home or the caregiver. Patient's response, you can select whatever you thought. If the patient is willing and able, willing, unable. If the patient is unwilling, or the patient is willing but they have barriers impeding full participation. And with the caregiver, same thing. And the caregiver availability, please don't leave it empty. Putting what kind of availability the caregiver has. New or changes to plan of care. If there's any change to the plan of care, please select a yes or a no. And if you say a yes, it will have you go what changes you made. Discharge planning every visit. You have to do a discharge planning with the patient or the caregiver or whoever is present, the doctor, and you always have to do this every visit. Care coordination every single visit, and because you're always reporting to myself or Victoria, you can care coordinate with myself, Victoria, or the doctor's office. And once you put this there, you will put maybe my name or Victoria's name, or you can put nurse at PCP office. Or if you did take your name, you can put that there. And then regarding if you can be very specific on what you talked about, great, but you can also put visit summary. So once that is done, you will go into the health management. So over here, you always have to review the patient's medications while you're in the home. Review it, make sure everything is nice and accurate. And for here, if you have to add a new medication, that's when you go in to do the adding of a new medication the way I taught you how to do in the previous videos. So with every visit, remember you have to reconcile the medications. If you had to pill plan, you have to select this. And then if there's a new or change medication in the home, you select that. And if you identified any issue, you have to select this. And whatever you thought, exhibits and signs of heart failure, exhibits and signs of other comorbidities, barriers to health systems, insulin syringe pre-filled, if the home environment is unsafe, suspected abuse, which we are deemed reporters. So over here is where most people forget to do it. And I'm gonna take my time to go over it. So every skilled nursing visit, you have to incorporate the plan of care into the skilled nursing visit. And to do that, you have to go into plan of care profile, and then it will bring you to all the goals and their interventions, which you have had already educated your patient on. So for instance, if you educated your patient on fall precaution, you will click into fall precaution, and then you will select whatever you did. So patient identified to be a high risk for falls, SN to provide skilled assessment, identified and mitigate risk factors, provide instructions and reinforcement of teaching to prevent falls or injury, SN to instruct patient or caregiver on fall prevention, as well as assess need for therapy services. So click document, and then whatever, that was your intervention, whatever goal, and I will go with this last goal, patient will be free of falls during the episode, click document. And then whatever you do there, you should see it right here. So that is how you incorporate your plan of care into your skilled nursing visit. Medical necessities, we already went over it. It's auto-generated from the plan of care. And then we'll go into the skilled nursing note. We have a bunch of templates. If you need me to put a template specifically for you, I'm more than happy to do it. But you will go into the CPC Nurses Narrative 2, and it will give you an idea of how we want the notes completed. So the patient was seen today, where you found the patient, who was present. If there was nobody present, you've stated. You took the vitals. If there's anything out of normal, you stated and state that you reported to the doctor's office, which you know that you have to do. And if you complete your head-to-toe assessment and there's an issue, you will state head-to-toe assessment completed. Either there was issues or there were no issues, and what you did with the issues. Safety concerns, if there were issues or no issues, you state if there were issues, and you did what you have to write what you did with it. Medication reconciliation completed. You will complete medication reconciliation every visit, and if there are issues, you state what you did with it. If there was none, you state that there was no issues. And for the most part, at the end of your statement, you have to state why the patient continues to need home care services and why we need to continue to go back. And then you will also state that the patient, if the patient has a doctor's appointment, when the appointment is, if they have a mode of transportation. And for every skilled nursing visit, you need to state or document your education and your narrative. So for the last part, it states, skilled nursing services is required for wound care, medication reconciliation, teaching and education to prevent rehospitalization. Aim is to achieve all of patients' goals and interventions as it reflects on the care plan. For the patient to be safe and prevent readmission. Patient has an appointment on 10/14/2020 with Dr. Glenn, PCP. He has a mode of transportation and patient was reminded of this appointment. All questions answered, no questions or concerns. Will see patient on the next visit. Once that is done, you will sign with your password. That is your signature. Your password is your signature. And then you will put your date. Remember, the date of your skilled nursing visit, which is right here, should be the same date as it is here. Okay? And then you will complete, and that will be it. When you are on the field and you do your skilled nursing visit, I like to meet with you to do a few skilled nursing notes till you're comfortable. So please have that planned to do once you're on the field. We'll sit and then we'll document together on some of the notes. Okay. So we're going to go over writing orders. So to write an order, I prefer that you go into the patient's chart. For example, for this patient, we go in, then we will go into new, and then orders. Remember, I had told you to go under the create new orders or communication, and I had told you that there was another means to do it, and I like that means better. Yes, so this is it. So if you go under the patient's chart, patient's chart, and then you are in the patient's chart, right under the patient's, right on top of the patient's picture, or where the patient's picture is supposed to be, you will go to new orders. And it should open the order sheet for you. Once you are in the order sheets, it fills out the patient's name. It automatically does it. The name, the episode that we're in, the doctor, the date of the order. Whereas if you had gone into the create button, it wouldn't have done that for you, and you would have had to manually fill it in. So once the top part is already filled, you will go into the summary title. We will start with writing a medication order. So you will put into the summary title, medication order. Once you put that in, you will click medication order, and it will bring you to the patient's medication list. Once you are here, you will have to sign the current medication profile, and then add your new medication. You will put the start date and then the end date if there is an end date. For example, if it's an antibiotic or medication that you're taking short term, you will add that in here. But definitely put a start date. Put the medication in, the amount, the physician who ordered, the classification is auto-generated, the frequency, the route, and then you will click here to create an order once profile is signed. And then you will save and exit. Unless if you have more to add, you will save and add another. So once all these medications are ordered, I'm gonna cancel out because I'm not gonna put a medication. But once all these medications are entered, you will come back and then do a drug interaction, check all, check interactions. Once the interactions are checked, if the medication you added has a major drug interaction with any other medications, you will have to report that to the doctor. For example, for this patient, I'm sure all these have been reported already because the patient is on a lot of psych medications. So if the medication that you added is interacting with any other medications, please report it to the doctor's office and document that you did. So once you've done your drug interactions, you will sign your medication profile. Click this and sign. Once you sign, the new medication you added will automatically generate into here. So for this patient, I automatically had the discontinued medications, the change medications, all auto-generate in here. And then you will go ahead and click auto read back and verified, and then sign as of today's date. Anytime you're signing your order, make sure that the date on top here match the signature, and then click create order. Please don't click save, click create order, because if you click save, it's still gonna sit in the patient's chart. Click create order. And that is how you create a medication order. The next order that we're gonna go over is how to create a plan of care order. So for instance, when the nurse is going to do a start of care, they create a plan of care. And that plan of care is what the nurses use to take care of the patients. If while you're seeing the patient, other needs arise that need a plan of care for them, you will have to create an order for those. So, for example, new plan of care. And then you will click your plan of care order, and it will bring you to other ones that is already here, and it's based on systems. So SN, add order, which whatever order you would like to add. High risk potential infection, need for infectious disease, alterations to genitourinary, if the patient had a UTI, if the patient is constantly constipated, you can do this one. You can do alterations in gastro. If the patient is at risk for falls and you want to put something in there, whatever you're adding. But for this purposes, we're going to add one for constipation. So you will click this, you will click add, And then you will click alterations in gastro status. And then you will select constipation. And then you're doing your intervention, which is right here. And your goal, so optimal bowel evacuation. And that is your order. And then you will save and exit. Okay? For this purpose, I will not do that. Okay. For completing a wound care order, this takes a little bit of practice. But a wound care order, you will click wound care order. That is what you will put in your summary title. You will click the wound care order button. You will create a new order. Once the new order is created, you will go in and add the wound to the patient's chart. For example, if it's a pressure ulcer, you will click pressure ulcer and then complete this and add, save and create the order. Once the order is created, it will auto-generate in here and you would have to add that to your wound manager while you're in your note. If there happened to be a change in discipline frequency, same way, click change in discipline frequency. If it's SN, you will click the frequency that you would want it to change to. And we will review that, how to write a nursing frequency, we'll review that, okay? Supply manager, if a patient is low on supplies, you will add that in and you will say supplies. And click supply manager and add in whatever supply that you need added. Always remember, always check up order read and verified and sign according to the date that is here. It should match that date. It can be two separate dates now. Okay? Other is anything else that is not here. So you can always add other things like maybe the doctor orders us to do compressions. If the doctor orders for a hold of medications, anything that is outside of all these, you can put in the other section. And one other thing that can be in the other section is writing a missed visit order. For every visit that is missed, you have to create an order. So once the nurse goes to do a start of care, the start of care is a 19, sometimes 15, sometimes 20, depending on the patient information, page paper. It's a lot of information, a whole lot. But the system is able to provide a compressed form of this with all the pertinent information in there. And that is what generates the plan of care. So the plan of care is normally a 5-6 page paper, maybe 7 sometimes, but this is how the plan of care looks like. And this is your Bible for providing care for the patient. And I'm going to show you how to read a plan of care. So to view a plan of care, you go straight right into the patient's name, where they live, who their doctor is, what their prognosis is there, what their allergies are, medical, cognitive status, their nutritional status, functional limitations, activities permitted or restricted, safety, DME or supplies, advanced directives, caregiver status, psychosocial status, emergency preparedness, emergency triage, the patient's medications, and then right into their diagnosis. Then we go into the patient's parameters. And then the frequency, the nursing interventions, goals, rehab potential, homebound narrative, medical necessities, and then the narrative. So I'm going to go into details on that whole information again. So for this patient, they live in Chicopee. Their doctor is Park. Their prognosis is fair. They're allergic to two things, macrobid and morphine. They're illiterate times 3. They're forgetful. They're depressed. Heart healthy, no concentrated sweets. Functional limitations include bladder incontinence, endurance, dyspnea, moderate exertion, vision deficit. Activities permitted is up as tolerated. Home assistance required. Cane walker. Safety precautions include they're diabetic. We have to have an emergency disaster plan. Fall precautions, keep pathways clear, safety in ADLs, slow position changes, standard precautions, infection control, support during transfer and ambulation, use of assistive device. DME supplies the patient has grab bars, cane, elevated toilet seat, nebulizer, tap or shower, bench, walker. Those are the durable medical equipment the patient has. Advanced directive, her daughter, Marisol, is her advanced directive. Caregiver status, patient lives alone in a 1-floor apartment and has a PCA who lives down the block from her in the same apartment complex, has family who are also very involved in her care. Emergency preparedness and emergency triage is 4, which means that if there's any emergency, the patient can be postponed 72 to 96 hours without adverse effect. Medications the patient's taking includes Salium has, that's for constipation, lisinopril, metformin, Flovent, some eye drops, fluoxetine, amlodipine, cyclobenzaprine, albuterol, Docosate, and ezetimibe. And from reading these medications, you'll be able to tell the patient has some issues with constipation, they have high blood pressure, they have diabetes, they have some respiratory issues, they do use some ointments, they have some maybe depression, they have maybe asthma. So reading these will tell you some information of the patient. It will tell you how the patient presents. The patient's medications continue here. Some vitamins, atorvastatin for high cholesterol, ibuprofen for some pain, and some more high blood pressure medications. The patient's diagnosis include hypertension, urinary incontinence, radiculopathy of the lumbar region, chronic pain, dementia, diabetes, osteoarthritis, intervertebral disc degeneration, anxiety, insomnia, hyperlipidemia, asthma, and then depression. Under the orders for disciplinary and treatments, there is the parameters. The parameters are so important. So important because we go in and we assess the patient head to toe, and we have to report any vitals that are out of range. So for the heart rate, we want it between 120 and 60. So if the heart rate is more than 120, we have to report it. If it's less than 60, we have to report it. Temperature is 101.5 and 97. So if it's more than 101.5, we report. And if it's under 97, we report. Same for the respirations, 2510, pain, not more than 5, O2, not less than 90, systolic BP, 160 to 90. So if it's more than 160, we report. If it's less than 90, we report. Diastolic is 90-60. Blood sugar is 250 to 70. Blood sugar random is 350 to 70. So if any of your vitals fall outside of these parameters, they have to be reported. So let's go into the skilled nursing frequency. So the skilled nursing frequency can be a little challenging. So I will give you a few scenarios, but the way it's written is, for instance, for this patient, their frequency is 3 week 1, 5 week 8. The 3P always means 3 PRN visits for acute changes. Every patient has a 9-week episode. And like I said, at the end of the 9 weeks, we determine if the services need to be continued or ended. And if it's continuing, remember it's recertification. And if it's ended, remember it's a discharge. So for the 9-week episode, it can also be divided into 2 30 days. And remember, that was when I told you the LPN is supervised at each 30 days. So in every episode, the LPN is supervised twice. So if when we do the start of care, the nurse determines what the frequency should be, the nurse could say once a week for the 9 weeks, and that will be 1W9. The nurse could say 2 times a week for the next 9 weeks, and that could be 2W9. So the 2 is the first number is how many times you'll be going, and the next number after the W is for how many weeks. So for this patient is 3W1, 5W8, and 3P. So we went 3 times a week for the first week, and then we did 5 times a week for the next 8 weeks. So you see, the 1 and the 8 totals a 9. So that is the 9-week episode, 230 days, or 60-day episode. So once you have reviewed your parameters and frequency, it's important to read the next statement that is after that. That statement tells you the primary reason why we are in the patient's home. That is, skilled nurse developed patient's plan of care with patient or caregiver involvement to be countersigned by physician. Skilled nurse to perform complete physical assessments each visit with physician on hypertension and diabetes mellitus, requiring medication management. SN to assess other comorbidities, including dementia and other conditions that present themselves during the episode of care. SN to recognize interventions and minimize complications. Notify physician immediately of any potential problems that impede completion of patient's recovery and desired goals. So that gives you a general overview of the main reason why we're in the patient's home. So we are going down to the nursing interventions. So the nursing interventions is how we can find topics on what to teach the patients on while we are in the home. So this goes right from preventing readmissions to teaching the patient on their diabetes, psychosocial issues, preventing issues with polypharmacy, any medication issues, reinforcing teaching on pain, strategies on pain control, ways to reduce or prevent pain, skin integrity, talking to the patient about diet and hydration, talking to the patient about preventing pressure ulcer, oxygen conservation, COPD, dietary, O2 saturation. So we're going to be checking the patient's oxygen with every visit, hypertension teaching, genitourinary functioning, self-management and prevention of UTI, teaching the patient on the Alzheimer's, depression, diabetes again, foot care precautions, educating the patient on hyper and hypoglycemia, reconciling medications with every visit, pill planning for the patient, skilled nursing assessments to prevent falls, making sure that we're putting in the proper PPEs to see the patient, you doing hand hygiene, COVID-19 precaution, and so forth. And then in the goals, whatever intervention that is here, there is a goal in here that we should have known or read about it in order to know where we want the patient to be by discharge. The rehab potential is auto-generated from the OASIS start of care, and it says what the discharge planning and the rehab planning is for the patient. The homebound narrative is statements stating why the patient is homebound. The medical necessity is statements that confirms why the patient is homebound and needs home care services. And then we go into the admission narrative. Please, please, please make sure you read this thoroughly, because it tells you where the patient is coming from and how they landed with us and what we're currently doing for the patient. So it's important that you read all of the admission narrative. And that is the end of how to read your plan of care. So I would like to tell you what a NAMNOC is. And it's a short form meaning of Notice of Medicare Non-Coverage. So a NAMNOC is a document that is given to the patient when the patient is getting close to discharge. So we normally give the document to the patient probably a week or the last visit before the discharge. And this document basically states that the services are coming to an end and the patient will be discharged at this date. And if the patient does not agree to that reason, they can appeal to it or let the nurse know why they do not agree. So that is what a NAMNOC is. So if a nurse is seeing the patient, they give this NAMNOC the last visit before the discharge. And then that is the last time that nurse will see that patient before the discharge. Let me explain further. So when the RN does the start of care, we have the LPN see the patient throughout the episode. And then at the first 30 days, the RN will go do a supervisory visit. And then right before the discharge, the LPN will give the patient the NAMNOC. And that will be the last time the LPN will see that patient. And then the next visit after that, the nurse will discharge the patient. The RN will discharge the patient. So I just wanted to show you where you can find the NAMNOC. The NAMNOC is found in the admission booklet. This is what the nurse uses to do the start of care. And right in the back of the book, you can rip out the NAMNOC and sign it with the patient. So the NAMNOC has the patient's name, the patient's number, and their signature and the date. So we've put together a form that is called the Skilled Nursing Cheat Sheet. And it gives you an overview of what the expectations are once you are by yourself on the field. So it starts right from the head to toe assessment. It says that if there is an issue after assessing the patient, you have to call the physician office right away to prevent forgetting or getting overwhelmed. You need to inform the physician and inform the director of nursing of any issues. If it's a non-ER issue but needs to be addressed, please have the patient go to the emergency room. But if you're refusing, you can have the patient be seen by either Instead or Dispatch Health. Instead for CCA patients and Dispatch Health for Medicare patients. We are the patient's advocates. So if the patient has need in the community, we need to find resources for the patient that will assist them or help them. For example, if the patient has need with the senior services, we can call the senior services for help. For example, If the patient needs help with adult protective services, advice or information, caregiver services, if there's issues with healthy living environment, if the patient has issues with housing, if the patient needs any in-home services, meals, nutrition, and either they need nursing or rest homes, we can communicate to the senior services to assist the patients. Vitals. We need to document the vitals in the patient's home on the app. If there's any out of parameter numbers, we need to let the physician and the director of nursing know and also document it appropriately. State in your note that it was reported with or without orders. Medications. Medication reconciliation needs to happen every single visit. New medications, you need to write an order for them like we discussed. If there is a missing medication in the home, you call the pharmacy or the physician to obtain this medication for the patient. You need to reconcile medications with the MedMinder tray if the patient has some anytime before you switch the tray. Add start and stop dates for medications that have an end date, for example, antibiotics and prednisones. Add an infection log every time a patient starts an antibiotic. Wounds. Wound measurement every Friday. We already talked about that. If the patient is not seen on Fridays, then measure once a week. If wound is not looking good, please report it to the director of nursing and the physician in charge of the patient. Supplies. Patients need to always have enough supplies. If patient is low on supplies, two things. If the patient is CCA, remember, CCA provides their patients with all the supplies they need. Inform the office so supplies can be ordered through CCA, and then come by the office and collect some to last them while they wait for their orders. If the patient is Medicare, feel free to pick up supplies at the office. If it's a big supply, you can always let the office know and the supplies can be ordered straight to the patient's home. INR or Coumadin. Report INR readings to the physician for orders. Write new orders and change in the medication administration record. Report to office when the next INR is due. Stop date is very important. Education. Patients need to be educated at every visit based on care plan. Utilize the teach-back method. Teaching resources and materials are available at the office. Encourage patients to ask questions. CCA. All CCA patients have care partners. Please report every issue and change to them. Report all issues to their physician as well. Appointments. Please ask patients if they have any upcoming appointments and report to the office. This helps prevent missed visits, and we write a sticky to remind patients, put appointments on the blue stickies as well. Daily reports. Report that all visits were completed. If not, let us know right away if there's going to be a missed visit. If patients would like to reschedule, inform patients that you do not know the schedule and the availability of nurses, and you will let the office know. If the patient is once a week, let's be sure to move the visit to another day. But if the patient is 3 times a week, it's okay to miss the day. But please let us always know. It's very important. Frequently used contacts. Please make sure you have the contacts of Victoria, myself, Grace, Martinson, Adelaide, office phone, office fax, Western Mass Elder Services, Greater Springfield Senior Services, Dispatch Health, Instead, CCA, MedMinder. These are all the frequently used phone numbers that you should have in your phone for when you need them. Phone app. So for your phone app, please make sure that you start your visit while you are in your car. And then when you get into the patient's home, document as much as possible. Document the vitals, the last bowel movement, or you can go through the assessments as much as you can so that when you sit later to complete it, you don't sit for long. Once you are done, end the visit verification in the patient's home. So start the visit in your car and end the visit verification in the patient's home and have the patient sign. This is the only way to determine that you were actually in the patient's home. Skilled nursing visits. Please let your skilled nursing notes reflect the visit. All phone calls and follow-ups should be documented. Stickies. Check all stickies prior to the visit so that you don't miss anything. Blue stickies is episodic. It goes right through the episode. Yellow stickies is specific to the visit. Red stickies is from QA or some form of communication from the office. Finally, I want to inform you that there is something called QA, also known as quality assurance. This is a bank where all your skilled nursing notes are sent into once you complete them, and they are reviewed for any corrections. If there is anything that you need to correct, it will be sent right back to you so that you will complete them. Please don't leave them sitting in my scheduled tasks for too long. Whatever the issue is with the note, it will be communicated very well to you. Please complete it and return it right away. Thank you. Let's take a moment to answer these questions.